Now, I think we are coming to the endoscopic management of complications of acute pancreatitis, which is a fairly extensive field to cover. And it will be done by none other than Dr. Mukesh Kalla, one of the most senior and experienced interventional endoscopists in the state of Rajasthan and in Jaipur. Mukesh has an extensive experience in all areas of therapeutic endoscopy, and I'm sure he will be equally adept at handling the complications of acute pancreatitis. Mukesh, do you have a PowerPoint that you are
Yes,
sharing
sir.
with us?
Yes, sir. I'll share the screen if you
Go ahead,
permit,
and
sir.
then we'll take on after discussions after the PowerPoint.
Right, sir. So thank you, Dr. Kapoor sir and Dr. Saraswat sir for nice, pleasant words. So I have accumulated this data to make it concise and how things have changed since I have a practice of now 2 decades and how I learned gastroenterology and fluid collections way back in 98 and what we are doing in 2023 is altogether different. So as we all know, I mean, we'll go through about natural history of acute pancreatitis. 71% patients have a milder disease, but at the same time, 21% have necrotizing pancreatitis and 6% have a symptomatic pancreatic pseudocyst, which requires intervention. So if you go through the natural history of disease, in the milder form of the disease, up to less than 4 weeks, there is acute peripancreatic fluid collections, which later after 4 weeks will develop pancreatic pseudocyst. And for those patients who have a necrotizing pancreatitis, these necrotic collections after 4 weeks will become walled off necrosis. Now, the major paradigm shift is about the definitions and approach to these two situations. So this is like picture diagram of how things happen. For a milder nature of disease, you have a side duct disruption or you have a major duct disruption causing pseudocyst. But when you have necrosis, then you invite risk for causing walled off necrosis. Now, other complications of severe acute pancreatitis are infections, fistulae, pancreatic leaks, and pancreatic pseudocyst. Now, when we talk about endoscopy in acute pancreatitis, we can divide it into therapeutic intentions of endoscopy and diagnostic intentions of endoscopy. So, for diagnostic intentions of endoscopy in acute pancreatitis, is usually during the first 4 weeks of the treatment when you can, acute biliary pancreatitis, you can treat that. You can give feeding tubes, place NJs or NGs, and you can drain acute infected collections. But after 4 weeks is the major role of this endoscopy comes in. So if you see those patients of acute pancreatitis who have recurrent acute pancreatitis episodes, now we are wiser because we have a new equipment, this biotechnology called endoscopic ultrasound. This helps us to pick up small microliths less than 5 millimeters in size with the sensitivity and specificity of reasonably 90% plus. For doubtful stones as seen on ultrasound and pseudocalculus signs, this is one good diagnostic modality. And for pancreatic divisum, which is again an important cause for recurrent acute pancreatitis, endoscopy in these acute pancreatitis patients can be helpful in achieving the diagnosis. Now, what happens when you get a patient of acute biliary pancreatitis? So, not all acute biliary pancreatitis will undergo a ERCP. So, we need to know which patients are eligible for taking the advantage of this therapeutic procedure. So, those patients who have cholangitis, who have bilirubin more than 5 milligrams, who have clinical deterioration, along with stone detected on common bile duct on imaging, which can be ultrasound or MRCP. So these are the patients who would probably benefit from ERCP. In my personal opinion, I consider biliary ERCP in biliary pancreatitis as a very important step, and I consider it equivalent to doing a primary angioplasty because those patients who decompensate later have major complications. So for those patients who undergo early ERCP in biliary pancreatitis, they have a shorter stay, decreased complications, mortality and systemic complications tends to be significantly lower for those patients who have undergone timely and early ERCP. So as and when, I mean, these patients of acute pancreatitis, they develop pancreatic pseudocyst, they develop WAN, they develop extended WAN, disconnected pancreatic duct syndromes, and other vascular and luminal complications of acute pancreatitis can also be managed with endoscopy. So we will take up pancreatic fluid collection and how situations have changed over last 2 decades about the management of these two problems. So when you see a CT scan of a patient, on the left side is the pancreatic pseudocyst, which is clean, clear fluid. with sequelae of interstitial pancreatitis. On the right side, you see walled off necrosis, which would mean that the debris is solid debris, and through a simple 10 French or a 7 French stent, this debris won't come back. Todd Baron is one significant person in the sequence of development of because he was the guy who in 2003 gave the definition of WAN. So if you see the picture on your left side is pancreatic pseudocyst, and on the right side you see debris, which is called Waldorf necrosis. Now, why this is important to differentiate between pancreatic pseudocyst and WAN? Because if you go through this one particular presentation of Vardharaju from GI surgery 2011, you'll appreciate that the pseudocyst treatment success, whether surgical or endoscopic, is up to 93%, whereas WAN success was 93. This was in 2011. Things have probably improved since then. Adverse events are significantly more in WAN, and median intervention number of interventions required are more in WAN, and length of hospital stay is also significantly higher in WAN. Therefore, it's very, very important to know beforehand and before contemplating a procedure as to what we're going to deal with. Now, when you plan about managing acute fluid collection in the setting of pancreatitis, there are three possible approaches. One is traditional management, which is the surgical approach. We have learned from surgical approach about basic principles of how these collections develop. What is the natural history of these development, these collections, and how do you prognosticate these collections? The second important thing which came up way back in 2003 was first percutaneous drainage when intervention radiologist stepped in, significantly improved the morbidity and mortality of these patients. And somewhere around 2011 came in endoscopic drainage. This also became we became wiser with the development of endoscopic ultrasound and with the introduction of newer metallic stents, which were called LAMS. So if you consider surgery, it is a radical treatment. It has morbidity and mortality. There are few long-term complications. And now, but in today's era, it is used as a salvage therapy. If you consider PCD, it is good and it has really changed the scenario how you manage these patients, but they it inherent problems of multiple procedures, multiple upsizing, and 27% developed fistulas. And for endoscopic drainage, the multiple plastic catheters can be planned. There is no external catheter is needed. It suboptimal drainage of debris was there till the lamps was in, but now with availability of EUS and lamps, the scenario is improving further. So if you go through the data now, till up to 1990, it was only surgery. Then after 1990, gradually percutaneous drainage came in, and endoscopic drainage came in 2007 onwards. So this is a very interesting slide, wherein you see that from the year 1980 up to 1991 is all open surgery till the year 2000. It was all about sending these patients. I remember in early 2003, 4, 5. And in the moment you see air inside the lesser sac, we used to call our GI surgeon and we used to open those patients. Patients did well, but there were fraction of patients we lost also. So, but the important landmark papers which came in was one Panther trial and another important study which was from Dr. Pramod Garg at All India Institute of Medical Sciences. These two studies were, I would say, landmark studies. 35% patients with infected necrosis don't need necrosectomy. Minimally invasive approach is better than open surgery. Conservative treatment is comparable in infected pancreatic necrosis. But now, after since the Tension trial and Miser trial, these two trials have really revolutionized the changes in the approach to the pancreatic fluid collections. The endoscopic management is now compared to minimally invasive surgical techniques. So this was the Panther trial, which compared the endotherapy to surgery, and they found in the cases of one and found is a landmark publication. I consider this, and was really multicentric trial, which changed the scenario how we look at management of one. So in this particular situation, you will appreciate that endoscopic treatment is superior to open surgery and non-inferior to minimally invasive surgical procedures. Now, when you go further into this Panther trial, you will appreciate that open necrosectomy, when it was compared with step-up approach of IR, the overall results and the further complications down the line, 5 years follow-up, the risk of diabetes, hernia, death was significantly lesser with the step-up approach of PCD. Therefore, I would say that PCT was superior to surgery as per this trial. Then there was another comparison of direct endoscopic necrosectomy, which was compared with the PCT, multiple PCT drainages. Again, this also said that endoscopic procedure was superior to placement of PCD in appropriate situation when available. Now, for pseudocyst management of the pseudocyst patients, if you see the chart there, the treatment success of pancreatic pseudocyst is 95% with endoscopy, 100% with surgery in this particular trial, which Varadaraju, all the procedures were done with EUS, whereas the surgical procedures were laparoscopic. The complication rate with minimal invasive surgery was 2%. Length of stay was longer there. And in US, the cost was significantly higher in surgical procedures as compared to the endoscopic procedures. So as to say that endoscopic procedure is less expensive, better quality, and it has less morbidity. Now we have this another good paper which compared use of percutaneous drainage with the endoscopic treatment. It also documented that as compared to percutaneous drainage, endoscopic drainage was associated with higher rates of treatment success, lower rates of complications, number of interventions, and shorter length of hospital stay. And of course, there was no fistula formations. Now we'll talk about the finer details of endoscopy in acute pancreatitis. So when and which patient needs this? These are symptomatic patients, preferably after 4 weeks, persistent wellness, cysts, ongoing organ failure, outlet obstructions, extrahepatic biliary obstructions, compartment syndromes, bowel ischemia because of pressure, and leaks into pleural cavity or outside. So when you have to do endoscopy in acute pancreatitis, the significant questions you need to answer on the radiology is whether it's a pseudocyst or it's a one or it's an extended one. Whether you're going to use intervention radiology as your tool, endoscopy, or you invite your surgeon to take the lead role. Whether you're going to use lamps versus plastic stents, and which is the optimal timing for doing these procedures. Again, Todd Barron is one very significant person who has contributed significantly to the understanding of this particular disease. And better to delay. This was the result of pointer trial, at least 4 weeks till the walls mature, so that there are no leaks in the abdomen, and we create a controlled internal fistula. So when you do endoscopy, there are three approaches here. This can be transpapillary, but the transpapillary is used through a routine ERCP scope. Plastic stents or nasocystic drains can be placed. So transmural approach is cystogastrostomy from the posterior wall of the stomach into the lesser sac where you have the collection. The moderate to large size opposing lumen to be accessible provides window for necrosectomy. This is important. And I was trying to answer the question of our IR colleague. The percutaneous endoscopic approaches can also be utilized, which is called tractogastrostomy, can also be done. These are new novel approaches for post-PCD fistula management. Now, what to do?
Two more minutes, please.
Right, sir. All right, sir. I'll go faster. So whether it should be a EUS or a conventional endoscope, significantly there is no difference if there is a bulge, but if there is no bulge, preferably use a EUS. So lamps or no lamps, lamps is better than having a plastic stent. So now about data, the advantages with the lamps is 1.6 centimeters wide stent is available, drains most of the debris. You can go with upper GI endoscope repeatedly. Costly equipment, demanding technically, and unfortunately not much data is available as of now. Now, a little word about disconnected pancreatic duct syndrome, because this is one thing which, if it is there, it will probably negatively prognosticate your treatment. If you see these patients who have disconnected pancreatic duct, their surgical interventions requirement are more. Their need for reinterventions are more. Therefore, one must try to assess whether their patient has DPDS or not. Therefore, to say and to conclude, you delay, you drain, and you debride. This is the approach one should apply. And what are our limitations of endoscopic procedures? They are distant, without impressions, extended bone, endoscopic expertise, if not available. Altered anatomy also precludes the use of endoscopy. Vascular complications. This is something new which is coming at the horizon of EUS, but there are limitations and the learning curve is still on this. So this is nasojejunal tube can be placed without pushing too much of air. Then you can manage pancreatic leaks by doing a pancreatogram and pointing out the location of the leak. And other novel uses of endoscopy in acute pancreatitis will be OTSC application, US guided thrombin coil placement for pseudoaneurysm. These are things which are gradually coming in. So the carry home message, this is one what we are using at our hospital. In approximation with the stomach, if you have a big one with less than 30% debris, we request an endoscopist to do it. But if it is a significant large, more than 30% debris, we request our laparoscopic surgeons to come and take over the patient. If there is no opposition and the debris is less than 30%, then we request our radiology colleagues to take up, or open or laparoscopic surgery can also be done. But yes, if it is more than 30%, then these patients would probably require open surgery, stable radiological setup, open surgery, stable or laparoscopic procedures can be done for these patients. Thank you for patient listening. I'll be happy to answer queries if any.
Dr. Saraswat.
Yeah, okay. Thanks, Mukesh, for an extensive coverage of a large area which is also rapidly expanding.
Yeah, sir.
Series trials have come in, and innovations are the rule. As time goes by, before one particular procedure matures, a superior procedure is available. The instrumentation and the technology for the endoscopist is also improving.
Right.
So I think coming back to walled off pancreatic necrosis, who does what? I think you would agree that the recent guidelines that have come out from the European Society of GI Endoscopy, as well as position papers from the American Society of GI Endoscopy, also tell us that triaging the patient and finding out who is going to be the best responder to endoscopic therapy is becoming increasingly important. Advantages, I think I'm sure the time was just too less for you to cover all these. In
Yes,
a
sir.
patient in the ICU who is a very high anesthetic risk, bedside procedures and drainage and even necrosectomies can be carried out. And one limitation that you pointed out was distant collections that are far away from the stomach, paracolic or in the pelvic, in those areas. That is where I think the percutaneous endoscopic necrosectomy technique that you mentioned as tractogastroscopy, that away from the stomach, you can still use upsizing the percutaneous tract and then using the endoscope to get in and do this. I think the All India Institute people have published some experience with this.
Yes,
So
sir.
versatility is quite good. So between ward, the minimally invasive surgical procedure versus endoscopic pancreatic necrosectomy versus percutaneous endoscopic necrosectomy, and how do you see these different procedures, and which patients would be suitable for which of these interventions?
Sir, I think, I mean, if the collection is less than 30%, these are the patients which were best managed by endoscopic procedures. If you have one which is more than 30%, the laparoscopic results probably would be better than doing endoscopic cystogastrostomy, because this is one subpopulation of patients where the even in spite of having a 1.5 centimeters opening with the lamps, the gets clogged in again and again, and there's risk of sepsis in these patients. So these the probably this particular subset of patients would be more for minimally invasive surgical patients, but I am pretty sure that IR patients, IR for necrosectomy of 30% is not an appropriate solution. So it will be the better results will be with endoscopy or vis-a-vis minimally invasive laparoscopic surgery.
So for endoscopic pancreatic necrosectomy, you go in with the scope, and
Yes,
there
sir.
are a lot of different schools of thought whether you should use hydrogen peroxide or not, whether you should actually try and remove debris or only remove what is shed and away from the walls,
Yes.
and problems of major bleeding because vessels can be disrupted if you are aggressive in removing necrotic tissue. So, what is the approach that you follow at your center?
Yes, sir. I mean, at our place, we are using the Roth's basket, or I mean, anything which go helps us to go in and accumulate the necrosis and bring it out. If you call about the near, if you ask me about what is new in the horizon, there is like endorotor or necrolite. There are two new technologies which have come in, and they have passed the phase 3 trials in US and heading for the approvals, wherein they have created the aspiration catheters of up to 3.8 millimeter in size, which have rotors inside, and they suck out the necrosis and they mince it in smaller pieces so that there is no residual area. As for H2O2, I am still doing it, but if you ask me about what literature says, this is my institutional practice and my decade-old practice that after having done placed the lamps there, we go in and try to bring out as much as possible, and we come back with a nasocystic drain in place. We request them to place hydrogen peroxide repeatedly. But the data is, I mean, equivocal about use of hydrogen peroxide.
Yes, I think these are.
If Jyoti, there is a question in the chat, if you can take that. That how do you estimate the amount of debris? Because you said less than 30, more than 30.
Yeah,
So
that's
radiologically we assess it, sir.
It's a radiological estimate.
Yeah, we normally we have certain precautions we do right before the procedure. We have we do a ultrasound, then we do it under EUS, which is a reasonably good modality to assess the amount of necrosis present in it.
between these two images, I think MR and MR imaging is generally thought to be superior to
Yeah,
CT
MR
scanning
is
for
supposedly a better
assessing the
image. Yeah,
quantity
agree,
of
sir.
pancreatic necrosis.
Correct, sir.
US gives you a very good idea, but if it's a very large cavity that all of which you can't image in a
Right.
few feeds of US, it may be difficult to get a
Yes.
quantitative idea more precisely. So that is
Right.
where MR imaging would help a lot in making out percentage of necrotic debris in there.
Right, sir.
Any
Right.
concluding remarks, Dr. Saraswat?
Right. I think it's such an extensive area that it's very difficult to just have a few remarks. I think among the various procedures that are being done by the endoscopist, one that is gathering a lot of attention and good evidence-based data are emerging is for walled-off pancreatic necrosis and different approaches to tackle it effectively. Similarly, for disconnected pancreatic duct syndrome, the approaches are for draining can be supplemented and can be managed. But for GI bleeding, I think the IR approach is generally considered superior because it is
Yes.
more versatile. Whereas for splenic artery aneurysms, aneurysms on the left half of the abdomen, the percutaneous access is quite easy. And I think Dr. Naresh was pointing about the principles of angiographic management, while his point that he made from the angiographer's point of view are absolutely correct. But uh, in aneurysms in the pancreatoduodenal arch or on the right half of the abdomen, because of the extensive vascular supply, I think there is no good long-term follow-up data of successful endoscopic management of glue. Most of it is in the splenic artery aneurysms that they've been followed. In fact, Dr. Pravi Rai from SGPJ has also published a good case series of patients in whom he has done. One of the first publications was his, and I think his long-term follow-up of almost 1 year was complete recovery and a very in the about a small series of about 10 or 12 patients, there was no rebleeding. But yes, I think um, handling what I think Dr. Shastri pointed out on the right half of the abdomen, aneurysms with multiple areas of vascular supply, it is difficult to have good control over the endoscopic technique. And I guess the angiographer using various techniques would have to see how best they can manage it. Unless there are questions from the house.
No, I think we'll have to move on. So thank you.
One point I want to add in this, sir. You are telling about the right and left half of the abdomen, and pseudoaneurysm in the left abdomen can be managed by percutaneous route. But in a practical way, when we were not having cath lab in our department, we used to tackle these pseudoaneurysms by percutaneous route, and we used to inject usually thrombin in these pseudoaneurysms. But in our experience, we have seen that the percutaneous route is not that efficient, even the dealing with the pseudoaneurysm.
Right, so that is the IR experience. I'm just telling you the endoscopy experience with glue injection and not thrombin was this small series that I am aware of was from my department in Lucknow. We had followed about 1 year and about 10 odd patients, and they didn't recur. So I guess these are small experiences. These are short durations of follow-up. So it is very difficult to be very categoric about one or the other. These are again techniques that are evolving. But the versatility of these approaches needs to be kept in mind. In fact, the endoscopist got this idea from the percutaneous injection technique of the
It's
IR
basically
guys
clean
that you
game,
can
sir.
do
It's
it by
practical.
US.
Yeah.
Okay,
Right.
I think we need to move on. So thank you, Dr. Saraswat. Thank you, Dr. Kalla. And I hand it over to Dr. Shastri to chair the next presentation.